Hello, everyone, and thank you so much for joining us tonight. My name is Benjamin Quinn, and on behalf of Harvard Bookstore, I'm so excited to welcome you to tonight's event with Abdul El-Sayed and Micah Johnson discussing their book, Medicare for All, A Citizen's Guide, in conversation with Dr. Mary Bassett. Tonight's event is part of our ongoing virtual event series. As we remain digital for the time being, we're so excited to continue the work of bringing authors and their writing to our community during these difficult times. Especially now, it is through the support of authors and our beloved readers that we're able to make events like this happen. So thank you so much for continuing to show up week after week. For tonight's event, we will conclude with some time for your questions. If you'd like to ask the speaker something, locate the Q&A function wherever it may live on your Zoom display, where you can submit all your questions. We'll get through as many as time allows. If you go to the chat section of this presentation, I will shortly be posting a link to our website where you can purchase your copy of Medicare for All. If you already have a copy of the book or would like to contribute to this series and our store in a different way, I will also be posting in the chat a link to our website's donation function. We greatly appreciate any and all support you are able to extend to us at this time. And lastly, as you may know if you've participated in large virtual gatherings lately, which I assume all of you have, technical issues may come up. We do apologize in advance for that. If any technical glitches do occur, we will do our best to resolve them as quickly as possible. And we thank you for your patience and understanding. And now it is my pleasure to introduce tonight's speakers. Abdul El-Sayed is a physician, author, educator, and former gubernatorial candidate. Previously, he served as health director for the city of Detroit, where he oversaw the revival of the city's health department following municipal bankruptcy and privatization. A leading voice in health policy and progressive activism, he is also the author of the memoir Healing Politics, A Doctor's Journey into the Heart of Our Political Epidemic. Micah Johnson is a resident physician in internal medicine at Brigham and Women's Hospital, just on the other side of the river in Boston. He previously served as a health policy fellow in the US House of Representatives, advising state and presidential campaigns on healthcare reform. As a prolific policy activist and scholar, his writing has appeared widely in venues including the American Journal of Public Health, the AMA Journal of Ethics, Slate, and Scientific American. This evening, they are joined in conversation by Dr. Mary Bassett, current director of the FXB Center for Health and Human Rights at Harvard University. With more than 30 years of experience in public health, Dr. Bassett has been a committed advocate for health equity in the United States and abroad, previously serving as New York City's Commissioner of Health from 2014 to 2018. Tonight, they'll be discussing Micah and Abdul's book, Medicare for All, an invaluable guide to the American healthcare system that US Representative Ro Khanna calls a labor of love for the American people and the healthcare system they deserve. As the ongoing pandemic has no doubt exemplified to many, if not all of us, healthcare policy in the United States is a notoriously complex issue, harboring partisan resentments, legal challenges, as well as just lingering foundational inquiries. What healthcare system do we strive for as a national body? In Medicare for All, our physician authors offer a powerful examination of the process of making universal healthcare a reality, identifying the obstacles that continue to impede progress, while also offering a cogent and meticulously constructed plan for transforming the way we give, receive, and pay for healthcare. We are so deeply excited to be joined by these incredible minds this evening. Without further ado, I'm delighted to turn things over to our speakers. The digital podium is now yours, Abdul, Micah, and Mary.
Thanks very much, and thanks for that introduction. I'm going to get us started by saying, of course, because I direct a Center for Health and Human Rights, I believe in the right to health, but achieving that goal has been elusive in the United States, as we've witnessed in the past months. So it's a really good time for all of us who've supported Medicare for All and all of us who want to learn more about it to hear our speakers this evening. So I'm going to start off by asking Abdul and Micah to just give us an overview of the book. And then after that, we'll begin with a conversation and then open it up for questions. So over to you both.
Thank you so much, Mary, and thank you for your leadership. And I have to say, as a younger health commissioner in a smaller city, I was really grateful for your leadership and your mentorship as I took on the work of rebuilding that health department. And in particular, the work that you've done to demonstrate the way that racism interrupts our ability to provide basic public goods when it comes to public health and healthcare. And I'm looking forward to the conversation today. I want to give some context to this book and how it came about. Micah and I, we came to this work in the context of politics, which is kind of the way that most people have come to this work or come to know what Medicare for All is. I was running a campaign for governor. This was 2 years after Bernie Sanders had first run for president, and Medicare for All had become a household phrase. And we realized that the right place for a conversation about Medicare for All probably wasn't the political arena. Rather, it was situated in the lives that people lead. Rather than talking about state and federal budgets, we thought that it was more important that people situate this in a conversation about their own kitchen table budgets. Rather than talking about public policy, it was more important that people were talking about people. And this is what this work was intended to do. It was intended to put this conversation back into the personal. So that next time when we do have a conversation in our politics about where healthcare ought to go, which is fundamentally in a democracy a question of who we are and who we ought to be, that we've situated in the stories of ourselves and one another and our communities and the society in which we want to live. And that was the main thrust of this book. Micah?
So first, just want to say thanks to Harvard Bookstore so much for having us. I've lived in Boston. This is now my 6th year in the area. Lived during medical school for 4 years in Cambridge and Somerville. And while we were writing this book, I spent many afternoons wandering around Harvard Books looking for inspiration. So it's really a pleasure for me to be able to be with you all tonight. And the perspective that I try to bring to this book is as someone who's always believed that healthcare is and ought to be a human right. And then getting to medical school, and even here in Massachusetts, where 95, 96% of people have some form of health insurance, and nevertheless seeing day in and day out how patients aren't getting what they need, whether it's not being able to afford a prescription, or being afraid to go to the doctor at all, or going bankrupt after they do get sick and have to go in with an emergency. So what I saw is that the terms of our political conversation just weren't matching the problems that patients and their doctors and nurses were facing every day. So that's the spirit that I hope that it can bring to the book. And Abdul, why don't you get us started talking about some of the history of what we're dealing with here?
Absolutely. Sometimes when you talk about Medicare for All or single payer healthcare, people pretend like there's no historical context for it. And it's interesting how in the absence of our history, it's easy to rebrand something as fundamentally radical, when in fact, from the very founding of our country, the question of how we promoted the general welfare, which is right there in the preamble of the Constitution of the United States, that was a question that was an open one. And there is a long history of our policymakers and our political leaders picking that up and using it as justification to engage with the question of directly providing people healthcare as a fact and function of American government. And so I just want to read you a little bit from the introduction of the book about the first time in American history that we had a direct healthcare program. As early as 1798, the Fifth Congress passed and President John Adams signed an early attempt by the fledgling republic to promote the general welfare, an act for the relief of sick and disabled seamen. At that time, international trade was vital to the well-being of the United States, although being a sailor was a particularly dangerous trade. To protect its merchant marine, Congress passed the law creating a system of government-run hospitals for seamen, funded by a mandatory tax on their earnings. As science advanced through the 19th and 20th century, American government acted as a catalyst to convert new knowledge into broad improvements in general welfare, improving sanitation, putting fluoride in drinking water, ensuring widespread vaccination, funding new hospital construction, and guaranteeing health insurance for senior citizens. Modern healthcare has developed tools that humanity couldn't have imagined in 1787, from vaccines and antibiotics to robotic surgery and targeted immunotherapy. Because of these advances and so many others, nearly 250 years after the people of the United States ordained and established the Constitution, American life expectancy has more than doubled. And yet, perhaps by the standards of our time and the power and wealth of our country, we are yet failing to promote the general welfare. Life expectancy in the United States is nearly 6 years shorter than in Japan, the longest lived country in the world. American infant mortality ranks 55th in the world, and American health disparities by race and socioeconomic status are among the world's steepest. Perhaps worse, life expectancy has stagnated, even falling, for 3 straight years between 2015 and 2017. Rather than the infectious diseases of the past, the diseases with the predilection for the young today are diseases of despair, drug overdose, alcohol misuse, and death by suicide. For the population at large, cancer and heart disease are the top killers. For this mediocrity, Americans pay by far the steepest price for healthcare in the world. We spend 18% of all of the money in our economy on healthcare. We are projected to spend over $12,000 per person on healthcare in 2021, double the average in comparable countries, and our costs are increasing rapidly. I wanted to start with that, just because I think it's really important to situate the context around where we are and where we've been, so that we can chart where we want to go, and put the conversation about Medicare for all, about the proposals for reform, in the context of that history and in the context of that present. I also think it's really critical for us to think a little bit about how this is personalized, how people experience healthcare in this country. And for that, I'll turn it back to Micah, who can read a bit about a patient that we got to profile for this book.
Yeah, so I want to read a section of the book where we tell the story of Lisa Cardillo, who's a remarkable woman who we got the privilege of knowing while writing the book. And her experience, I think, really shows what we're dealing with. So I'll get right to it. Lisa Cardillo will never forget her 15th wedding anniversary. After waving goodbye to their 3 children, Lisa and her husband Dominic drove across the state to Granville, a few miles from Lake Michigan. They had more than their anniversary to celebrate. Dominic, who'd suffered a malignant brain tumor at just 33 years old, was finally 3 years past his cancer diagnosis. They were eager for a fresh start. But just as they were about to enjoy the day on Lake Michigan's sandy beaches, Lisa felt a sharp burning in the center of her chest. Then came the crippling nausea and abdominal pain. Though Lisa was 36 years old and otherwise healthy, she knew that something was terribly wrong. The Cardillos knew better than to call an ambulance. Dominic's had cost them $800 when he was first diagnosed. They rushed to the car and started Googling nearby hospitals. Dominic stepped on the gas. Lisa's left arm started to go numb. As Lisa walked into the emergency room, she went into cardiac arrest. With her heart no longer pumping blood, she crashed to the floor. The emergency room personnel started performing CPR then and there. Over the next 9 agonizing days at that hospital, Lisa was diagnosed with a heart attack caused by spontaneous coronary artery dissection, a deadly tearing of one of the arteries that supply blood to the heart. Thankfully, Lisa survived, but those 9 days were only the beginning of her ordeal. Because all of this was extremely expensive. The hospital sent a bill for $185,460. For 5 months, she had to wear a defibrillator vest. That was another $5,000 a month. Then more bills for cardiac rehab, follow-up appointments, and prescriptions. And here's the thing. The Cardillos have health insurance. Unlike the 30 million Americans who don't have it, they have health coverage through Dominic's job as an automotive engineer. Before Dominic's diagnosis, they had tried to save on premium costs by choosing a plan with a high deductible, meaning they would need to spend more before insurance kicked in. That left them with $12,000 in uncovered medical bills. Their friends eventually started the GoFundMe page and threw an in-person fundraiser to partially allay their debts. Together, their friends and family raised nearly $8,000, just enough to get them back on solid footing. But when January 1st rolled around, their deductible reset, and they found themselves back at square one paying for Dominic's ongoing treatment. Beyond the financial toll, there was the personal toll. Lisa spent hours on the phone with the various hospitals, clinics, labs, and imaging centers where they owed money, not to mention pleading with their insurance company to cover the cost of this or that treatment. More than once, she'd found herself crying to the faceless insurance bureaucrat on the other end of the line. She told us, quote, "When your medical bills become more stressful than your husband's brain cancer diagnosis, something is not right." Morbidly, Lisa jokes that her favorite bill is the one for cardiopulmonary resuscitation, the manual CPR she got in the emergency room. For $568, the hospital personnel saved her life. But because she hadn't met her deductible, she paid for it out of pocket. "It's the best $568 I ever spent," she said. But should she have had to spend it at all? So I find Lisa's story very powerful because Lisa and Dominic are the people who are supposed to be doing well in the current healthcare system. They've got so-called good private health insurance through Dominic's job. And nevertheless, when illness strikes, the insurance just wasn't there for them and they faced financial ruin. And so many Americans face that choice. Either they're not getting the care they need, or they go for it and they end up paying dearly for it. So when we're talking about Medicare for all, there are lots of groups we should have in mind, primary among them being the 30 million Americans who don't have any insurance. But even the people with insurance are an important part of this conversation. And when we talk about Medicare for all, it's not only covering everyone, it's making coverage more comprehensive, and it's cracking down on the high charges for care, and it's cutting out a lot of the administrative waste that jacks up these prices. But of course, to get from here to there requires a lot of political work, and there are obstacles. So Abdul, why don't you tell us about those?
We're in a moment right now where it's easy to look at the past 5 years and think, wow, we tried that several times and it just hasn't worked. Maybe the conversation about Medicare for all has passed us up. But I want to remind folks that don't mistake a local minimum for a true minimum. In fact, this conversation has moved leaps and bounds over the last 10 years. And a lot of that is because exactly the point that Micah made, which is that people like Lisa are now included in the group of people whom our healthcare system is failing every single day in ways that leave them at risk of bankruptcy or without the healthcare that they need. In the past, the conversation about healthcare reform almost always was about how we provide health insurance and healthcare coverage for low-income people, which should be enough to motivate change. But the fact is that right now, the median American is suffering. Just to put it in perspective, the average deductible, that's if you are privileged enough to have private health insurance, the average deductible is $3,500 for the median family of four. That median family is making about $69,000 a year. If you do the math, that means that just to pay their deductible, they're paying an entire biweekly paycheck just to make that deductible. And I don't know a family that can go without a biweekly paycheck earning that much money. And so there is a moment right now where the system is imploding onto itself. It is extracting too much from too many in ways that create the space for a renewed conversation in a drive to push. The other point that I'll just make is this. What the industry wants us to believe is that this conversation is over, that it was litigated in 2019 and 2020, and that's it, they won. The fact of the matter is that we are all losing, and that means that we have to win. And we have an opportunity in this moment to reignite this conversation, to center it back in the personal, and to make the personal political. If we do that, I do believe that the conversation has never been more ripe for what we need to do to take on the industry and the way that it has corrupted our healthcare system. And we believe that Medicare for all is a conversation that we all as a community need to be having right now. And so with that, I'll turn it over to our discussant, Dr. Mary Bassett, and we'll go from there.
Well, thanks very much for that. And I want to start out by saying that I've reread the book. I read it in galley proofs early on, but you had changed it since I read it the first time. And I want to say for anybody who isn't sure what Medicare for all means, this book is for you. But for people like me, and I've supported single payer government funded health insurance for many, many years, I learned a lot from it too. So it's really very clearly written. It has tons of facts for people who want facts, like facts. It has also these real stories that help us to remember and put the facts in context. So I want to thank you for that. I start out by, remembering things. In New York City, which of course is a big city, we figured that some 800,000 people said that they didn't get a prescription filled because they could not afford it. And these were mostly people who had health insurance plans. And of course, despite the Affordable Care Act, which survived the attempts to overthrow it, if that's the right word, despite that, we still had many people who lacked health insurance at all. And that, of course, included the undocumented. Why don't you just say a little bit, you've explained pretty well why we are not doing well enough, but how would Medicare for all work? What does it mean? Why do people find this word single payer so important when we talk about universal health care? And what would it do to our healthcare delivery system Would it dismantle it and make us have a system sort of like the National Health Service that the UK has, or those kinds of things might be of use to people?
Yeah, very helpful point. And we say that Medicare for all, it's a simple idea. The government guarantees comprehensive health insurance to all Americans under a single publicly funded plan. And the difference between Medicare for all, which would be a single payer system, the hospitals and doctors that are private today would stay private. So it would be more like the Canadian system. That's different from a national health service like the United Kingdom, or even like the VA here in the United States, where the government owns the hospitals and employs most of the clinicians directly. So that's why single payer has become the term, where your doctor is still your doctor and their employment doesn't change, but it's having us together as a society funding publicly the dollars that go into when you do go in to see your doctor in hospital, how they get reimbursed.
It's hard for me to figure out, thanks for that, why the barriers remain so great. We're paying a lot of money for healthcare as a nation. Our government is paying as much for healthcare as many governments that have a national health plan pay per head. And we still leave millions of people without any health insurance at all. It's just hard to figure why we can't get there. I know that the people who oppose it have been the medical profession. Well, I hope that we've learned our lesson. Doctors are now mainly employees compared to the way it was when I went to medical school. And then, of course, there are the insurers and the hospitals systems who oppose single payer. Can you just explain to me what's driving them? Presumably, many people who work in the health sector are committed to improving health. Why do we have this terrible situation with high costs and bad outcomes?
Yeah, it really is a conundrum, Dr. Bassett, and I appreciate you asking the question. All of that money that we spend on healthcare is the reason why healthcare is what it is, because the folks who take that money want to keep taking that money. That really is the fundamental problem. And we have a system in this country where we have a profit motive at both ends of the payer-provider continuum. Insurance companies are incented to make a lot of money, and hospitals and doctors are incented to make money. And the reality is that increasingly, as you noted, it's not really doctors anymore. It used to be the fact that most doctors worked for other doctors or owned their own practices. That's actually an anachronism now. Most doctors today, especially young doctors, are going to be working for large employees. And those corporations who dominate both the provision and the payment for healthcare want to keep their profits intact. And to put a perspective on it, right, in 2020, health insurers made often double what they had expected to make because the elective procedures that are their most expensive line item to fund were canceled. And so where hospitals lost money, the payers made money, and they spent a lot more money lobbying government because they realized that they could double dip. Let me explain what I mean by that. Wow. They spent $151 million lobbying across 845 lobbyists. That's almost 2 lobbyists per member of Congress. And the reason that they spent all this money lobbying is because they knew that nearly 15 million, depending on how you count, 5 to 25 million people lost their jobs and therefore lost their health insurance. Now, they saw a business opportunity to make even more money. And so what they did is they lobbied Congress to do exactly what we're doing now, which is instead of putting those folks who had lost their employer-sponsored health insurance, which by its nature is insecure, as the pandemic demonstrated, right, instead of putting them on a government plan, they lobbied to make sure that we, the taxpayer, would be subsidizing their COBRA coverage to keep them on their for-profit corporate health insurance. And so they were able not just to make money through the cancellation of those elective procedures, they were able to go ahead and double dip and say, all right, so a lot of people lost their insurance. So we know that we can get the government to pay more into the system so that we can make even more money. And to put it in perspective, the crazy thing is that these health insurance CEOs, part of their bonuses are a function of how much money they make, which is, of course, made by denying people the healthcare coverage that they needed and already paid for in the form of premiums, right? And so these folks made tens of millions of dollars off the pandemic. And this is an egregious example of why the system is what it is, because these folks have a lot of money to make, and they have a lot of power to move government and to move public opinion toward making sure that they sustain their profit. And so a lot of this, right, as we think about where we are right now, yes, we need to pass Medicare for all at some point. But today, we actually need to just pass HR 1. Like, that'd be a really important first step to getting there, because so long as these corporations can leverage their heft to rent seek through government, they're going to continue to persist in a direction that puts their profits over our patients.
I think you better explain what HR 1 is for all
yes,
of us.
Yes, HR 1 is a recently passed bill through Congress. It would have to get through the Senate, which has a number of different democracy reform proposals inside of it, which makes our democracy more democratic, right? So it undoes a lot of the systemic voter suppression that keeps systemically poorer and browner and blacker people out of our electorate. And HR 1 would be a set of policies that would seek to infuse those folks and make it easier to vote, which of course, is how a democracy ought to work.
Have I understood you correctly? Because I thought nothing could show what the problem with job-based health insurance was more clearly than a pandemic that led to huge job loss. And many people have lost their health insurance. We know that although under the Trump administration, the ACA wasn't overturned, but it was greatly weakened. Medicaid was weakened. So we had more people uninsured over the Trump years than had already been uninsured. And then all these people lost their jobs and lost their employee-based health insurance. But you're saying that somehow the insurance companies continued to fill the gap. They didn't lose money. People just lost their health coverage.
And I think it's a disappointing turn of events too, because and one of the things that we outline in the book, during the 2020 Democratic primary, there was a consensus on the direction to go for reform. It was folks like Bernie Sanders and Elizabeth Warren who thought that everyone should have public health coverage. And it was people like Joe Biden and Pete Buttigieg who thought a lot more people ought to have public health coverage, but still give people a choice. So there was consensus in the Democratic Party, and that was a big deal because what the Affordable Care Act was, it was a totally different paradigm. It's let's give people subsidies to buy private insurance in a marketplace. It's a totally different, it's Romney Care is really a Republican, and even going further back, a conservative idea with the Heritage Foundation originally. So
with Nixon,
why is it
with
now?
President Nixon, really? Yeah.
Yeah, exactly. And so the question is, with that consensus that the party had reached, why is it that now we're going in the other direction where there is all of the provisions are purely to get more people on private insurance? And, I think it does speak to the power of the industry to lobby. And, speaking a bit from my own time in Congress to put some color on it, it's not just, campaign donations and people that rely on this financing to fund their own election campaigns. It's the fact that there is a war chest in all of these industries where if you are a member of Congress and you take a vote that the industry doesn't like, that they have millions of dollars overnight where they can run attack ads in your district with all the disinformation and negative talking points. So members of Congress often are scared by that power. And I think there's, putting people on public coverage is so popular. I mean, even right now, the public option, we're polling at like 70%. These things are just extremely popular.
Right.
So it's hard to understand why we're not doing that unless you confront these problems in our politics.
Right. Exactly. One has to wonder sort of what the roots are of some of these enduring problems in US politics. And a lot of my own work focuses on thinking about race and racism. And I wanted to raise the idea that part of what's going on here with the idea of resistance to a government-run program is the way in which government-run activities have been branded as things that help Black people particularly, and all people of color, and are really sort of spending too much money on the wrong people. And if you could just talk about the way in which universal benefits can overcome this belief that government support for human needs always ends up somehow helping the wrong people too much in the eyes of white America.
Yeah, I really appreciate you bringing that up, because I actually believe that the single biggest obstacle to achieving Medicare for all in our country right now is racism. And I'll give you a couple of pieces of evidence to structure that argument. The first is a really interesting poll that was done of swing state voters in 2020 that asked how many points Donald Trump would lose if he supported Medicare for all. And I'll give everyone a second to clear their cognitive dissonance before I share the answer. So if Donald Trump decided he wanted to run on Medicare for all, he would lose a sum total of 2 points.
Wow.
And so the point here is that it's not about the actual policy. It's about the question of who the policy is intended to benefit. So you're exactly right. Heather McGhee wrote a fantastic book that just came out middle of February called The Sum of Us. And she uses the analogy of the public pool.
Yeah.
And the fact that after the Brown v. Board of Education decision, Black residents realized that this meant that not just schools had to be desegregated, but all public resources had to. And that was an era where there were these massive, beautiful public pools that had been built for public use, but really that only meant white people because it was the Jim Crow South. And rather than open these pools up for the Black children, they just paved over the pools. And it's not that it just hurt the Black kids who never got to go to the pool, but also hurt the white kids too, who, over the winter looked back and were like, where's my pool? And it reminds us that there is a narrative of deservingness that has always put Black and brown people last. And when we talk about public provisions and public goods, one of the biggest obstacles to being able to establish them is this narrative of deservingness that is racialized in the way that almost every one of these public policies that we talk about is. And so if we're serious about being able to pass Medicare for all, we are going to have to really confront racism as an obstacle to public goods and public goods provisions if we're going to be able to do that. And to give you a sense of this, if you look at the states that expanded Medicaid in the ACA, they were almost always states that were in the North. And in the South, those states were the places where they were least likely to expand because of the profound history of racism. And we often think about the South as being a place where it's predominantly white, but it's actually just that the political dominance and the political class tends to be white, but a vast majority of some of the populations in the South are actually Black. And so
half of the Black population of the United States still lives in the South.
Right. Yeah. That's right. And it was those attitudes that kept those states from being able to expand Medicaid. So the point that you're making is a fantastically important one, and one that we can never overlook when we think about how we're going to get this done.
Right. And additionally, everybody should remember that this had no cost to the states. This was a federally funded program. This was simply a benefit that they that was declined out of this sort of ideological disposition that has got to include race. But many people may be familiar with the phrase deaths of despair and the analysis done by Princeton economists that showed that the case in Deaton, that showed that mortality rates in the white population and a certain sector of non-college educated white men were going up and had been going up since the 1990s. This is really unusual. And one of the interesting and surprising things in their book, the data on declining life expectancies was something was published in medical journals, but in their book, they explore the idea that part of what's driving the growing despair of working class Americans, including white Americans, is the high cost of healthcare. And the fact that to hire a low wage worker requires this huge investment by the employer, so that the proportion of the cost of that worker that's healthcare is very high. So for a high wage worker, it may seem like it's worth it to you to spend $15,000 a year or whatever it is. Whereas for a lower wage worker, you just may decide that it's just not worth it, or you start squeezing the wages, and real wages have been declining for this group. Could you want to talk about that a little bit? I was surprised to see them be so forceful on the high cost of the US fragmented healthcare, not only in terms of poor quality care and many people with no access, but its impact on the rest of the economy.
Yeah, I can definitely speak to that. And, first just add one addendum on the conversation about Medicaid and who's deserving. One of the things that's proposed in Congress is now essentially, it's almost a bribe, where it says if the states who have not yet expanded Medicaid, if they do expand Medicaid, the federal government will basically pay them extra for all of their Medicaid patients. So it's not even that there's now no cost to the state to expanding coverage to the folks who would qualify for Medicaid. It's states are willing to lose out on money to not expand Medicaid, right? States are willing essentially to pay for the privilege of making sure that the undeserving people don't get healthcare. So I think it makes us see that so much of this is not just about economics and policy. And my view is that it was naive to think that you would be able to persuade people in the red state governors to expand Medicaid by giving them more money, because it's not about money, it's deeper.
Right. I agree completely with what both of you are saying, that there's no kind of easy way around reflecting on the 400-year legacy of the United States that began with the importation of enslaved Africans whose work generated the wealth that helped to propel the United States into the wealthiest of nations. So I don't see any other way around it. And it somehow seems to make it into just about everything that we can identify as things that we have to overcome. So I'm glad to hear you mention that. Yeah. I had another handful of questions that but I know that, we have some questions coming in, but one thing that I wanted to mention is that not all unions, you talked about how the miracle of getting Medicare through, a universal entitlement that John LBJ elbowed his way through, included a coalition between seniors and unions. But although there have been some important unions that have supported Medicare for all, some unions are kind of quiet about it, at the least, and not all are that enthusiastic. Do you want to comment on that? I would think that they would like to see workers getting higher wages and not just having a struggle to retain health care coverage.
Yeah, I really appreciate the point you're making here, Mary. There is in my first book, I talked about this idea of an epidemic of insecurity, and it's based on the notion that over the past 40 years we have been the victims of a governing consensus that tells us that we should be privatizing the basic means of a dignified life. So all of these public goods that ought to be provided publicly end up being provided by major corporations to the exclusion of some of us and the extraction of all of us. And the consequence of that has been a need to hold on to what you have for fear of losing that too. And I think that insecurity, the psychological work of that insecurity, is that when a better option is proposed, you are so used to losing what you have under the guise of a quote unquote better option that you categorically deny any change whatsoever. And so, when you look at unions, it's clear that if they did not have to negotiate for healthcare coverage, that those would be dollars in union members' pockets rather than dollars in health insurance corporations' pockets. And yet it has become one of the few things in an era of union decimation that they can reliably offer union members. And so the micro politics of it get in the way. At the same time, though, we have to remember that there have been incredible unions at the front end of this too. So probably the most important force for good when it comes to Medicare for All has been the National Nurses Union. The SEIU is not far behind. And these are the folks who represent people working inside the system, whether it's the nurses or it's hospital employees. And they see the system for what it is and have been on the front end of bargaining for and fighting for a system that is more just and equitable, where they wouldn't have to negotiate these costs on behalf of their unions. But it remains a real challenge. And I think what's happening in time, though, is as the quality of the healthcare that is being bargained for starts to fall in absolute terms, even if it's relatively good, in absolute terms, the quality is getting worse and worse and being eroded by the high price of care. I think we're going to start to see more and more movement of unions in the direction for Medicare for All.
Yeah, I just don't see any other solution. And now that I'm not in government myself, I get to say that without any caveats. I really don't see any other solution than Medicare for All. I remember when I left city government and went to work for a private foundation briefly, their insurance coverage included a benefit that I'd never heard of before. And that was somebody who would go take care of advocating with your health insurance company for you. So there's this new category of job now. Not only are there the legions of people coding and the legions of people billing. Now, when you get health insurance, they come up with a person who will be your advocate so that you don't have to have the hassle, which is enormous, of having to negotiate to get your health insurance benefits released to you. So we just keep adding more and more types of roles when a much simpler solution is actually available. So I wonder, I hope I'm not making us all feel too discouraged about this because it has been a long haul. I never would have imagined that something that I supported when I entered my own hospital training at a hospital that was very under-resourced, that ran out of penicillin, believe it or not, in a hospital in New York City. I supported this type of strategy for funding healthcare access for all. And here we are now, many years later, still working at it. But as you point out, we have made progress. And the terms, the pandemic, for example, offers another example of why it's so important that people not have their insurance tied to their jobs. I wonder if I should see whether we have about 15 minutes remaining. If I should see what we're getting in terms of questions here. All right, there I have various questions from anonymous attendees. The first one reads this way. Opposition to universal health care often references policy constraints. One of those dodgy answers that seem to suggest that there's no foundation or platform that could support a large system as Medicare for all. Can you talk a bit about the opposition and what policy plan your book proposes?
Yeah, I would say I think about it in opposite terms, where I think if I have one conclusion from working on the single payer plan with Abdul and then all my own policy work, the barrier to Medicare for all is not a policy barrier. There's no practical barrier to doing it. It's not an economic barrier. It's a political barrier. And I think being clear about that piece is very helpful in terms of having the right conversation about Medicare for all and having the right strategy around Medicare for all. And yes, there are many important policy questions. And, we have a chapter in the book that kind of recognizes the fact that Medicare for all is a big idea. And there are some policy choices to be made. How much do you pay doctors? What exactly is covered? Does a patient pay anything out of pocket? There are real questions there, but all of those are answerable. And there are a range of plausible responses to each of them. And I see the next question is about the cost.
How much would it cost? Yeah.
Just to kind of loop that in here, to say that it's not an economic barrier. The most expensive healthcare system in the world is the current American healthcare system. So it shouldn't be surprising when we learn that Medicare for all would cost similar or less than the current system. And now it's not just, the 10 or 12 studies showing that we cite in our book, but even just in the last couple of months, the Congressional Budget Office, which is seen as the gold standard for how much a piece of legislation is going to cost, also say that Medicare for all would cost the country less than our current system. So it's not an economic barrier to doing it either. So I think it is right to, when we're thinking about what it takes to get this passed, to really focus in on what the political challenges are. And I think that gives us the right strategy for moving forward.
So it's really about organizing. And I guess, maybe people don't know that the United States, we've talked about the falling life expectancy, but also in terms of outcomes of any number of common conditions, the United States fares less well than its other wealthy nation counterparts. So we're spending more money by far than any other nation per capita for healthcare. The government share of that is approaching 2/3 or something over a little bit over 60%. And then we get outcomes that are not as good. And we have a life expectancy that is falling. And of course, the COVID pandemic has led to on average, it's predicted about a year loss of life expectancy, which is kind of huge. But it was falling before that. I just don't understand why this isn't making people jump up and say something has to change here. But I guess that's for all of us. We can't really expect the insurance companies or the hospital systems to do that.
Mary, we have a whole chapter in the book called Organizing versus Advertising. And in a lot of ways, all of us over the last 4 years got to see the principal strategy of disinformation, which is to accuse people of doing the thing that you yourself are doing mendaciously, right? And so Trump would say, you're doing this, when in fact it was exactly what he was doing. The insurance industry employs the same approach. They say, you, dear Medicare for all supporters, are going to ration healthcare, when in fact the principal rationer of healthcare is the insurance bureaucracy. They're going to say you are going to cost too much, when in fact health insurance costs far too much, to the point where 10% of people can't afford health insurance at all. And they're going to say that you are going to take away people's choices, when in fact the choice that most people want is the choice of physician. And the most important gatekeeper when it comes to what physician you can see is the insurance industry. And so we are going to have to build a movement of people who are moved by their story and moved by their own experiences to build together to move the system and to inure the rest of the population from the advertisements that are going to frame this issue as if it's coming for theirs. And This is, for us, it was a principal reason why we wanted to write the book, because we know that for a lot of folks, they sort of think that this is not going to happen for us. And that's exactly what the industry wants us to think. It's exactly what politicians who are cozy and comfortable with the industry want us to think. And we have a responsibility to rebuild that conversation. And we are hoping that people see themselves in their own story in this conversation. There was a question from Michael who asked, how do we win over the 159 million Americans that are covered by private insurance? Here's the thing. Most of those folks, right, they benefit from not having to actually use their insurance. And the problem with it, right, is that the operative term in the word insurance is sure. And actually, when you go to actually use your insurance, that's when you realize the thing is not really all that sure. And it's stories like Lisa's of people who are quote unquote insured, where there is nothing sure about their experience. That I think ought to be motivating us. And this is the conversation we need to be having. Are you actually sure that it's there for you? What does a deductible actually mean? And even if you haven't had to pay it, what would it mean for you to have to pay down that $3,500, that $7,000, that $15,000? What would that mean for you and your experience? Because the entire advent of insurance was about protecting people from the shocks of healthcare costs. And it no longer does that. So the question becomes, well, what's the whole thing worth anyway?
Another thing you talk about in the book is that people aren't as healthy as we should be. And part of that is related to healthcare. But part of that, and this is the last question up there from Natalie Alinos, who I work with. Part of it is due to the conditions of people's lives, the so-called social determinants of health. And can you talk about how you think that the healthcare system ought to relate to that? Should they care not only about the delivery of services inside the hospital, but what neighborhoods look like for the people who use their services and what their lives are like?
I think, I'll be honest with you.
This is talking about housing and about, I don't know, when I was at the health department in New York, we tried to get hospitals to sponsor what we called healthy bodegas. That's the name for the corner stores in New York, and sort of incentivize them for stocking fruits and vegetables and serving, a sandwich with a piece of fruit rather than a sandwich with a bag of potato chips and water instead of soda and stuff like that at their deli counter. Anyway.
Yeah,
you'd be honest.
I know, I really appreciate the question. And I'll be honest with you, I come to healthcare and healthcare policy as an epidemiologist and former health commissioner. And the issue here is not that healthcare is the answer to health disparities. The issue is that healthcare is the obstacle to our ability to actually get to talking about health disparities. Because so long as healthcare accounts for 18% of our entire GDP, so long as healthcare is the major albatross in the room, so long as healthcare continues to suck up all of attention, it's very difficult for us to put it where it ought to be, which is under the broader guise of public health, in a space where we can actually invest in everything from housing to clean air, to clean water, to healthy food, to walkable communities. And we don't do that thing because right now our political economy forces all of the money through our healthcare system, because a lot of folks have a lot of money to be made off the back end of it. And so rather than engage with it that way, I do think we need to put healthcare where it ought to be and create incentives for government, who becomes the insurer for you, to be able to do the things it needs to do to keep you healthy across the life course, rather than to sequester a ton of money into a healthcare industry that does not allocate it efficiently and could care less about investing in your well-being. And I'll just put it out there. Our healthcare system makes money, right? The system generates money when people get sick, right? There is a political economy disruption, in fact, incentive not to prevent illness. And that's why we have a system that is so fundamentally underinvested in when it comes to public health, and we're suffering the consequences of it every day.
Right. No, there's nothing built into the system that rewards them for keeping people healthy, particularly.
And I can add one thing
it is sickness care. And let's see.
I can add one thing on.
Yes, please, Micah.
There's no doubt that the conditions that people are living in is the primary driver of their health. But what we often forget is that the healthcare system itself often makes those conditions worse because of the economic drag that it puts on people's finances.
Yeah.
So for low-income families, 1/3 of their entire compensation goes to healthcare costs. 9 million Americans are driven into poverty by medical costs every year. Hundreds of thousands of people are going into bankruptcy due to medical costs. And it works the other way too. We've seen that when you give people high quality insurance, so in studies, for instance, of Medicaid expansion, people's the rates of evictions go down, the rates that people reporting of buying healthy food goes up. So I think there's also a sense in which by fixing the way we pay for healthcare and by getting these costs off the backs of low and middle income people, that we actually go a long way towards improving the broader conditions, alongside, of course, all the other direct policies that are so badly needed.
Yeah, no, thanks for that addition. And I don't think that we can minimize the sort of the drain that Lisa describes of trying to get the benefits that you know you are entitled to, because the insurance companies have the power to deny, and then you have to fight to and badger to get your benefits, and that's exhausting. I mean, it's been a while since I practiced clinical medicine, but at the end of every day, I used to reserve an hour to negotiate with insurance companies for my patients over things like, could they get physical therapy after a open heart surgery? Things that, I would imagine I was talking to some guy with a book this high who was looking up to say whether or not my patient, who I saw, but they never saw, could get the services they needed. Yeah. All right, let's see, we have time, I think, for one more question. And the question is, are physicians gathering round? I notice I'm the only one who put the doctor in my title, but both of you are also medical doctors. Are physicians beginning to raise their voices, having opposed Medicare and Medicaid as a national organization of the American Medical Association, and endorsed segregated hospitals and barred Black physicians, et cetera? Are we beginning to see physicians raise their voices for Medicare for all?
Absolutely. And, we're at a watershed moment, really. And, I'm looking at the attendees, and I see so many of my young doctor friends and colleagues that I'm so happy that joined this evening. And it really is a difference. And there are a few reasons for it. One, as you mentioned at the top of the program, that the role of the physician is different now than it used to be, where so often we're now the frontline worker in a huge impersonal system, where so many of us are finding more common cause with nurses and pharmacists and environmental service workers about folks who are really on the front lines, whether it's in the pandemic or otherwise. And realizing that our interests and priorities are not only separate from the big systems that we operate in, but sometimes in conflict with them. So I think we see this now in the data too, where the median physician is now supporting Medicare for all, and a really historic endorsement over the last couple of years of the American College of Physicians, a very mainstream medical group, the second largest after the American Medical Association, explicitly supporting Medicare for all as a path towards universal coverage. And I think it's really important because for all the reasons that you've described, doctors have a tarnished history on this issue. And because so many of the big players in the healthcare industry aren't going to be moved, the insurance industry and the pharmaceutical industry are not going to be moved on this issue. But what happens when nurses and doctors and pharmacists, or the scientific researchers who work in the pharmaceutical company, what if there's a new coalition in the healthcare industry of people who are actually doing the work, band together to say that, look, this would actually be good for us, and more importantly, good for the people that we serve? So I think that's one of the things that gives me the most hope when thinking about where this movement goes next.
So solidarity with our patients is a pretty natural move for physicians who are involved in patient care. Any final comments from either one of you? I hope everybody who's joined us this evening will get the book if you haven't gotten it already. Give the book to someone else if you have got the book. And I'll ask Abdul and Micah if they'd like to make some final remarks. And
yeah, well, first of all, thank you for such a lively discussion, and thank you to the Harvard Bookstore for hosting us this evening. I just want to remind people that we are not bystanders in our politics. And politics isn't just something that happens around us. In a democracy, we have to choose to move the public conversation and to move public policy. And my hope is that in this moment, as we watch around us this pandemic and what it's shown us and how it's devastated us, and everything about the normal before it, should motivate us to build a new normal where we no longer assent to this governing consensus that robs us of the basic means of a dignified life. That's a choice that we make. And my hope is that we are willing to put ourselves and our time and our energy and our resources into this work. And if we can do that, I believe deeply that we can build that world. And so really grateful to be able to engage and enjoy this conversation with you tonight.
all right, thanks very much.
Yeah,
Micah, do you want to add?
Yeah, just to say again, Dr. Bassett, thanks so much for leading our discussion, and to the Harvard Bookstore for hosting us. And just to say to everyone that this issue isn't going anywhere. And I think the daily ups and downs of our politics, it's easy to get discouraged. But the fact is that people are still going to be struggling with healthcare tomorrow and the day after, and there is no way to put this issue in the dark. It's only a matter of time to when we confront it again. So I'm grateful that so many of you are passionate, that want to stay a part of this conversation, and look forward to working with all of you in the future.
Great. Well, I think that's a excellent note to end on. I just want to thank our speakers. Thank you, Abdul, Micah, and Mary, for joining us. This was a fantastic conversation. And thanks to all of you out there for spending part of your evening with us. Please learn about this incredible book and purchase Medicare for All at harvard.com. I've put the link in the chat a couple times, so please check it out. On behalf of Harvard Bookstore here in Cambridge, Massachusetts, enjoy the rest of your week. Keep reading and stay safe, everyone.
Thank you.
Thank you. Thanks for writing this great book. Thanks, Micah. I'll have to find you in Boston. And good night, everyone.
Look forward to it. Good night.
Ciao.